So, welcome everyone. Thank you so much for attending let's see, it's the fourth Cord Connects this calendar year. It's been a lot of fun so far. We've had a whole lot of really great pearls, educational pearls, as well as administrative pearls. And we're really looking forward to the session today. It's going to be led by Dr. Miriam Kulkarni and Dr. Adrian Cordarello. And the title is The Calm in the Storm, Equipping Learners to Handle the Emotional Burdens of Emergency Medicine. And I'll just go ahead and quickly give an introduction for Dr. Kulkarni and Dr. Cordarello. So Dr. Kulkarni, Miriam Kulkarni is a graduate of Robert Wood Johnson Medical School and the Jacobi Montefiore emergency medicine residency. She's been in residency leadership since 2009 as an APD and a PD, and she is currently the program director at St. John's Riverside Hospital in Yonkers, New York, as well as a regional dean for the Lake Erie College of Osteopathic Medicine. Her interests include simulation, resident and medical student feedback and remediation, and we're so glad to have her here. And Adrian Cordarello, I don't have a bio for you, Adrian, so I'm winging it, but I think I can do a pretty good job, actually. So Adrian Cordarello is a graduate of the St. John's Riverside Hospital Emergency Medicine Residency. He did an EMS fellowship at Northwell FDNY. And then he returned to St. John's Riverside Hospital as core faculty and is the research director there. He has many interests, including biostats and any like calculations and statistics, pretty much the nerdiest things you can think of, but he's also very good at it. So
that was perfect, Mary. Thank you.
Yes, absolutely. So welcome, Dr. Kulkarni and Dr. Cordarello, please take it away.
So thank you everyone for coming. I think both of us are really excited to be giving this talk today. And I think all of us would agree that one of the things that makes emergency medicine so challenging is that our patients come to us when they have had a bad day. Being an EM physician means treating patients who are having the worst day of their lives, navigating a healthcare system that is stretched to its breaking point, working with other physicians and healthcare providers who are also stretched to their limits. It's an emotionally volatile situation, and it's that way all day, every day. And it can feel overwhelming. It even feels overwhelming to me sometimes, and I've been doing it for a long time. But especially when you're at the very beginning of your training, when you're just learning to navigate the physician-patient relationship, when you're just learning to navigate the healthcare system, when you're just learning to navigate clinical medicine. And so in this presentation today, we're going to make the case for why it's important to train your learners to communicate in these emotionally challenging situations, and also to train them to sort of prepare them for their own emotional reactions. And we'll show you some methods for doing that.
So unfortunately, angry or these kind of emotionally charged encounters, they're a daily reality in the emergency department. Every shift, if not more frequently than that, you encounter someone who's upset, who is kind of overwhelmed emotionally, either because of the situation they found themselves in, being in the emergency department, or for other factors, many of which outside of our own control. Even going further than that, in one survey from 2022, found 77% of ED staff had endorsed experiencing aggression. And the way they defined that was both kind of physical contact, but also threats, physical threats of violence, and a lot of direct hostility, someone who was, screaming in your face. Whether or not they actually laid hands, that was considered an aggression. And 77% in any kind of survey we're looking at, especially when the subject matter is a bit sensitive, you have to consider the possibility of underreporting of certain things. I like to think that in a survey of our peers, we're going to want to speak to some of the challenges that we face. But from this, we know that at least in this pool, at least 77%, which is a huge amount. It's a crazy amount once you realize just the magnitude of how often and how frequently we're dealing with this. The majority of physicians, of emergency physicians, have to encounter this. often on a daily basis, if not fairly frequently. Um, Now, these encounters, are often described in a number of ways. No one, likes when this kind of thing happens. If someone is up and screaming, it's inevitably kind of an uncomfortable position to find yourself in. And these can kind of comprise some of the more difficult parts of the job. We can be great at the medicine, great at everything else, but there's this kind of personal interaction, especially with someone who is so upset, that can be fairly draining, between all of the other responsibilities, that kind of fall upon us in the emergency department. Um, and even more than that, I think it's important to consider who is having these conversations. Of course, we will. Of course, every member of the team is going to be involved in this. But often the first kind of line, the first line defense, if you want to think about it that way, it's going to often be the most kind of junior person, the lowest person on the totem pole, who's going to kind of face the brunt of a lot of this. Often that kind of falls upon either junior residents or learners or people that, are the first contacts that the patient might have. And then they're often sort of met with the brunt of a lot of this, as does nursing as well. In that way, it adds to kind of some of the expected stress that we would expect in any junior resident. Imagine an intern already dealing with all of the kind of difficulties that come with intern year, and also feeling kind of not quite ready to deal with some of these emotionally charged conversations. In fact, there was a study in 2020 showing that often trainees both found that they didn't really feel comfortable in talking to patients that were increasingly aggressive or hostile, or just having these talks that were emotionally charged. Um, but not only did they not feel prepared, they would often feel remorse and sort of guilt that they weren't better at handling conversations like that. Often, the most common reported groups were people that were angry or people that were, suspected of seeking narcotics or other kind of drugs in the department, where they knew that they needed to address something, but didn't really feel equipped to handle it in the right way. So on one hand, we're placing a lot of these people, a lot of kind of our um, kind of youngest in terms of experience, rather, kind of newest faces in the department to deal with these kind of difficult, emotionally charged scenarios that they don't really feel specially equipped to handle, which can be difficult. Um, so the educational kind of gap exists all the way down. It isn't something that is often explicitly taught in medical school or in early residency. It's inevitably something that's touched upon, but there aren't very many kind of structured, formal instructions on, say, anger management, as a study in 2023 found. Often residents are kind of learning by doing. They're seeing how things are handled in the department. They're learning from the attendings and the more senior residents. And that's how they kind of have thus far, it seems, been kind of building up the skill in handling these difficult conversations. But that leads to some inconsistency. People have different approaches on how to handle talks. People have different kind of social skills and strengths and different kind of personalized approaches that they want to bring to these situations, but often don't really have the formal training to do it. And this isn't something that you should just expect someone to sort of just figure out. De-escalation is a skill, much like a lot of the other skills that we do train. And so it's worth really considering it in that way. And so given that this is an important skill for our learners, it is something that I think we owe them some more kind of structured guidance and training through. Um, sounds like a lot of doom and gloom so far. This is obviously something important, and a lot of something that can become quite volatile if not handled well. And it sounds like, thus far, we're not kind of doing as much as we could be to address this. The good news is, though, there are interventions that do seem to work. Even simulated encounters, while that may seem counterintuitive up front, in that, how do you really truly simulate a tense situation like that? It still gives a learner or a trainee or anyone a framework in how to approach these difficult conversations. Kind of further studies have also found, true outcomes in the clinical side of things as well. With their clinicians endorsing higher confidence after having some structured training in this, having actually fewer complaints was one association that was found. And again, this is something that's teachable, and that we can really put work in and have a proven outcome that can make our learners more comfortable in handling these situations that very quickly can spiral out of control. So one thing that we actually piloted ourselves that has, similarly been done in other institutions, but we developed a kind of pilot structured training for difficult communication. So in this case, we included our medical students, and it was a combination didactic and role play training scenario. with sort of a structured, individualized feedback component at the end of it. Overall, we had strong results. People endorsed overall increased confidence in having these difficult communications, and specifically more confidence in some of the difficult discussions in our case surrounding patients who were angry and upset and wanting to leave against medical advice, as well as in disclosing errors, other types of difficult talks that aren't always sort of taught formally, but that we do owe our trainees. And given all of that, much like other skills that we teach, this is something that we should consider in that same vein.
So I think one of the pitfalls in how we teach our residents is we have this idea that bedside communications should be intuitive, and that folks who are good physicians, they just sort of know how to do this, and that's not how we teach things that we think are important, right? Like, imagine teaching a resident how to put in a central line, right? We don't say, well, if you're really a good physician, you should know how to put a central line in, and it shouldn't really be a thing I have to teach you. Or the fact that you saw me put one in, then you should be able to know what all the steps are and do them yourself, right? We take learners through those procedures with step-by-step guided practice. What I would suggest is that it's not intuitive to have these communications. It's not intuitive to manage your own emotional reactions to these emotionally charged situations. And just like, one of the reasons why we use guided practice before we ask residents to intubate, before we ask residents to put central lines in, those are high risk situations, right? Emotionally charged situations in the ED can be high risk for both the learner and the patient. And so, I would urge you to not assume that navigating these situations is intuitive. And just like our learners benefit from systematic teaching and practice in procedures, they benefit from systematic teaching and practice in these challenging communications. So we're going to go through how we help our residents build an angry patient toolkit. One of the first things to sort of start out with is normalizing having your own emotional reactions, right? We wade through other people's emotions all day long when we're working clinically. And, a lot of our patients are very angry or very sad or very demanding. And one thing to start out with is to just normalize the fact that you're going to have your own feelings back. Next slide, please. So the first thing that we do is teach them to recognize and deal with their own emotions. Next slide. And so we teach a technique called NAME. And so that's just that idea of when you're in the middle of an emotionally charged situation with a patient, when you have a patient who's very frustrated or very angry, to notice if you're having emotions, if you're having your own feelings back, if the patient is yelling at you or just, complaining and you're feeling frustrated back, to notice it, to acknowledge it, to kind of take a little pause and make some room for it. Oftentimes it means, taking a break if that's what it needs, what needs to happen, and just kind of allowing yourself to feel that emotion. Next slide. I think a lot of us have had that situation where we didn't do that, right? Where we got frustrated back at the patient, and it meant that we didn't handle that situation well, or we didn't handle it as well as we could have done if we had given ourselves a little bit more space. And then once you've noticed that you have a strong emotion, especially if it's a negative emotion, right? It's okay to feel that emotion, but it's not okay to act on that emotion. Adrienne, can you go back one slide? So you want to teach your learner a way of getting themselves to a different emotional place. And so I use the mnemonic Cal. So one of them, the first step is to sort of remind yourself that your control over the situation is limited, right? You can't control the patient's behavior. You can't control the patient's emotional state. You can't control the situation that led the patient to feel frustrated in the first place a lot of the time. All you can control is how you behave in that situation. And the next piece of it is to sort of get yourself to a different emotional state. And it's helpful to sort of alter your thoughts about that situation, right? To identify those negative feelings that you're feeling, right? I am frustrated because this patient is yelling at me because they were waiting for a long time. And to remind yourself it's not personal. They're not reacting that way because you're a bad doctor. They're not reacting that way because they hate you. They're reacting that way because they're in a frustrating situation. And then the L is for sort of just focus on listening to that patient, right? If you are sort of trying to rush ahead to make a diagnosis and move on with the rest of your clinical things you want to do for that patient, it's probably going to wind up making things more difficult, both because the patient isn't in a place where they want to be listened to, but also because your brain may not be available for diagnostic thinking at that moment. And making diagnostic decisions in that emotionally charged space can lead you to be more likely to make mistakes. Next one. When I talk about this with my, back on Adrian, when I talk about this with my learners, I talk about my own techniques that I use, both because I think it can be helpful to them, but also because I want to normalize for them that I feel these emotions too, right? It doesn't make you a bad doctor if you feel frustration in a frustrating situation. So the techniques that I use, I remind myself to let go of things that aren't in my control. I remind myself that the patient's frustration or anger is almost never personal. And it's helpful to me to think about why they feel that way, right? You've been waiting outside for 8 hours when you came to the ED because you thought you had an emergency. Well, of course that's frustrating. Next slide. And then once you've sort of gotten yourself to a better emotional state, you can recognize and deal with the patient's emotions. And we teach the HEAT technique. And that stands for hear, empathize, apologize, and take action. And the hear part of it, and I think a lot of us just kind of do this intuitively. Or have, I mean, I don't think it was intuitive for most of us. We learn to do this, right? You know, when the patient is really angry or the patient is really frustrated, the patient is really sad, that anything else you want to do with that patient sort of has to wait, right? And that you need to kind of hit pause and stop what you're doing and sit down and engage fully with that patient and give them your complete attention. And not just give that patient your complete attention, but give the concerns of that patient that have led to them feeling those strong emotions, give those concerns your full attention. And to allow them to talk about those concerns that they have and not interrupt them and just allow them to finish what they're saying. And it's really important to share with your learners that a lot of times it's as important for them to feel heard as it is for their problem to be solved. You may not be able to solve their problem, but you can listen to what they have to say. And then the next step is to empathize, right? To express empathy for the thing that they're experiencing that's difficult, right? I know you were waiting outside. I hear that you're frustrated that you were waiting outside for a long time. That must have been so frustrating when you were so uncomfortable. Next slide. And then we teach them to apologize, but it's really important to be specific about that because you're not asking them to take responsibility for things that are not in their control. You're asking them to sort of express regret for the circumstances that have made that patient so upset or so uncomfortable. Next slide. So, I'm sorry that you had to wait outside for so long. I understand that's really upsetting. That's really frustrating. And then the last thing we teach them to do is take action. And taking action means listing concrete things that you can and will do to help resolve the situation. And we teach them to sort of focus on giving choices where it's possible, and to try and leave the conversation with an agreed upon action plan with the patient. So, I'm sorry that the lab has taken so long to give us the results that we're waiting for. I'm gonna call the lab as soon as I go back to the nurse's station to figure out when the test will be run. If it seems like there's going to be a long wait, would you prefer to go home and have me call you when the results come back? Next slide. So like any skill, we feel like deliberate practice is important. And we really wanted to have our residents experience this in the very beginning of residency. And the reason we wanted to have them experience it in the beginning of the very beginning of residency, before their first clinical shift, was because when I thought about their clinical shifts, I was like, I am sure that they are going to have a patient be frustrated on their first shift. And I want to give them a skill set to deal with that. Just like I'm sure that they're gonna need to put an IV on a patient on their first shift, and I don't send them to that first shift with no idea how to put an IV in. It's the same thing. This is a basic skill that we use every single day. And because I wanted to have it for during orientation, because I wanted all of them to do it, because there's a lot else going on during orientation, like we really wanted to find a way to make this streamlined. And so what the method that we chose to use was very brief simulated patient videos. We had videos that went between 1 minute and 30 seconds and 2 minutes, and it was a simulated patient. One of them was a patient who was frustrated over a long wait time. Another one was a patient who was frustrated that he hadn't been prescribed opiates. And we would play the video that was included with a clinical vignette, and then had the participants role play. So one of them would play the patient, one of them would play the physician. They would get a chance to practice these techniques that we talked about, and then they would switch. But like any other kind of practice, right? So we wanted them to kind of go in with a skill set, but the real learning happens in the clinical arena. And so faculty development is really important, and especially because bedside manner is very personal, and every physician has their own sort of beliefs about how this should happen best. Every physician has their own emotional reactions to patients. It's really important to make sure that your faculty is on the same page, especially about that idea of managing your own emotions, and what's the best thing to do if you're having a strong emotional reaction to a patient. So there is a strong faculty development component to this. But just having the conversation, just sort of saying to residents early on in their training, we know that you're going to be having emotionally charged conversations with patients. We know that people are going to yell at you over things that are not your fault. And it's going to be difficult. And here are some, and it's normal to feel frustrated back, or sad, or angry. And here are some ways to handle it. Just having the conversation is powerful. Next slide. Another, I think, risk to sort of doing these trainings and teaching residents techniques to communicate with patients and to handle patients who are frustrated. I think it's really important for learners to be empowered to set boundaries. And so that's another thing that we were really careful to include in these workshops. There's a big body of research out there, some of which Adrienne cited. Violence in the ED, unfortunately, is really common. Both physical violence and like sexually and racially abusive comments are common. And there is behavior that is unacceptable. And we really wanted our learners to be empowered to not allow behavior that's unacceptable. And again, I thought it was important early on in their training to empower them to not accept behavior that was unacceptable, and to make them aware what the institutional expectations are and what resources are available to them, to teach them how to have those boundary setting conversations with patients. Because that's another thing. I think it's one thing to say to residents, well, it's okay for you to set boundaries with patients, but I think a lot of them need modeling for how to do that. But that's not really what the training was about, right? Because even angry or demanding behavior that's not unacceptable, that's not racist, that's not sexist, that's not physically violent, it's still exhausting, right? And it's one of the things that makes emergency medicine hard.
So, what more really needs to be said about burnout? This is something that's been well studied, examined, known colloquially for a long time at this point. Multiple studies have found that a lot of these emotionally charged conversations, even those that aren't overtly aggressive, even if someone isn't cursing you out or using slurs or being hostile or violent, even the smaller episodes, smaller incivilities, someone being rude and just a little bit aggressive where you're not concerned for your safety, but they just, add in that extra little comment that slowly eats away at you. Over time, even those smaller incivilities, they do build up and they do sort of work to erode your empathy over time. So, part of what we can do is the importance of recognizing this. And thankfully, there's more conversation about burnout. But even beyond that, it's training our residents and training each other and building up our skill set in a way that we can handle these situations in a way that we're kind of best equipped to do that. Burnout doesn't just manifest as being, fatigued. A lot of people become detached or shut down or become irritable. But this kind of thing, it isn't just another part of the job. It's something important that affects longevity in the field. It affects so many other kind of aspects of your life that once you're going in, the little things that you can do in your own practice and the way that we can impress this kind of skill set upon our trainees can help kind of approach this type of situation in a way that hopefully will give them at least a skill set so they don't feel quite as lost or quite as kind of alone in these kind of situations. Um, you know, further, some kind of more kind of disturbing numbers have come out over the last few years on, and known somewhat before as well, but on what exactly this toll kind of does to physicians. And really anyone who's sort of patient facing. The nurses will inevitably have to deal with a lot of emotionally charged patient encounters as well. But one recent study found that 21%, so more than 1/5 of ED staff had reported symptoms of PTSD following kind of violence. And the way they described violence in that situation wasn't just physical, it was the kind of hostility and direct, kind of aggressive, difficult, emotionally charged encounters. Again, that isn't something that we should sort of just brush off. It's something that we should collectively be working to minimize as much as we can, especially when a lot of the people facing these difficult conversations are going to be our learners. An intern on day one or day two will likely feel fairly unequipped to handle this kind of interaction, which is why it's important that we keep building up our curricula and structures and whatever kind of training we can give people to offer them the best approach to kind of handling these difficult conversations.
So there's a big body of research that suggests that when patients feel sort of emotionally connected to the provider and emotionally cared for by the provider, that patient outcomes are better. But there is also data that shows that it's better for the providers too. That meaningful relationships with patients are protective against burnout. Even like if the workload is high and the bureaucratic demands are high, that being able to form that connection with patients is protective against burnout and helps sort of preserve physicians' longevity in their profession. Next slide. Thank you guys for coming today. This is a thing that we really feel strongly about because, day after day, we're asking our learners to handle these situations that are really hard, to deal with, patients and other providers who are angry and frustrated and sad. And so it's really important not to sort of abandon our learners to navigate these situations on our own, and not just sort of provide a framework for how they talk to patients, but also a framework for how they handle their own emotional reaction to these situations. It really helps them not just provide better care for their patients, it helps them feel more fulfilled in their careers, and it helps preserve the longevity in emergency medicine. I think this is one of like the major challenges facing our field, and I think I think we can all do better. So thank you guys so much for joining us today. Does anyone have any questions? I see that there's one in the chat. Absolutely. I'm certainly happy to give the slides to anyone. So one of the questions in the chat was, can you guys have the slides? Which absolutely. I'm happy to give the slides to anyone. I don't know if it gets the presentation is put on YouTube, but the slides, individual slides are not, right?
Correct. Yeah. So it'll be even if you just have like a reference list or something like that, you could probably comment on the YouTube video as soon as it comes out.
Absolutely.
That would work great. Well, thank you both so much. That was an awesome session, and I find this, I don't know, just kind of reflecting on the last 3, 5, 10 years, I feel like this has become more and more of a struggle. And I feel like residents are needing more and more guidance on this particular thing. And it's really hard to know if there are just some more unique and maybe a little bit higher scale struggles with dealing with these conversations that residents have had in the last maybe 3 years, especially. I don't want to relate it all back to the pandemic, because I think it has more to do. It has to do with the pandemic, obviously. Like, definitely, there's a lot of virtual time that they spent during med school and maybe missed out on some of the many hours of in-person interaction during their education and training. But I think there's probably more to it than that. But I think it's a combination of that, and then maybe the patients have a little bit of a different demeanor when they come to the emergency department too, than they did, say, 20 years ago, 10 years ago even. And I'm finding that a lot of times I'm at a loss as to how to guide residents through this. So it's really, really helpful having those frameworks, and I'll take that back to the ED with me for sure.
Awesome, thank you. I mean, I think it's I did my own residency. I started in 2005, so like definitely I felt these feelings when I was a resident, which at this point is 20 years ago, because I'm an old lady. But I think the healthcare system has become more frustrating, right? I think that it's harder and harder for people to access care. And I think that's one of the things that makes it harder. I also think you might be right that they may be coming to us with a little bit less experience, and a little bit like our residents may be coming with less experience and sort of less understanding of how to handle these situations. But I do think if the environment in the ED is maybe a little bit more emotionally charged, and I think maybe that's a reason why.
Oh, Monisha's saying that's, yeah, I was actually wondering the same thing, Monisha. She's wondering if you have resources for the video clips or scenarios that you used with the residents as talking points to share.
I do. and Adrienne and I sort of had a little debate about whether to include them in the presentation. Mary, they're Joe O'Keefe, like some of them. So
Joe.
I mean, so basically, we also are an institution that has limited financial resources. So I took one of my residents and wrote a script and filmed him with my phone for 2 minutes. So absolutely, I'm happy to share them with anyone who's interested. We also are going to be doing, a study soon, where we're sort of looking at the effects that this training has on burnout, right? Because I'm hoping that this will lead to our residents sort of feeling more equipped for these conversations and make that emotionally challenged nature of emergency medicine make it a little bit easier for them, but I don't know. So we're also looking for collaborators as well. So I will put my email in the chat. Anyone can feel free to reach out to me. Any other questions?
I've got a question.
Mhm.
So I am one of the core faculty for our program in Des Moines, Iowa, and I kind of head up a lot of these, the wellness and this sort of topic is my realm for our residency program. And so when you mentioned teaching managing conflict similar to procedure, that I guess got me thinking, typically with procedural practice, we give them like graduated autonomy. So is that something that you do with managing conflict? Like, for example, as an intern, maybe they would watch you kind of take over with the patient or family conflict, and then as a senior resident, you are hands off and you let them handle it. Is that kind of what you guys do?
I guess in practice it sort of works out that way, but it's not formalized the way that we formalize it with procedures, and maybe it should be. I also think there's a lot more of these conversations than there are procedures. So I mean, would I send you to do a central line by yourself on your first day? Well, no. But do I send you to have these conversations, some of these conversations by yourself on your first day? I mean, I do, because I sort of don't have a choice, right? Because there's so many of them. Um, but I would say if I know it's going to be a very challenging situation, right? Like I know that it's an end of life conversation, or it's a big family conflict, or then I will either go with them, or it'll be a senior resident conversation. But do I send interns on their first day to deal with patients who are just frustrated? Absolutely, right? Because I don't like. There's so many of those conversations. So a little bit, but there's definitely room for it to be more formalized. And I think we also don't, that idea that Adrian mentioned, that there's sort of data that people feel a little bit of shame when the situation goes badly and they're not able to salvage it. I think normalizing that these situations are difficult, right, and that you can't always fix it. I think that's important too. But do I think our residents need more support than they're getting, even though it's important to me and I'm trying very hard to have it not be that way? Yes.
I kind of think of this as one of the topics that's like, when we're talking about things like remediation, resident remediation, it's so much easier, in my opinion, at least, to come up with a remediation plan for academic things than it is for things like professionalism. And I kind of categorize this in some of the, like, in my mind as almost the same as professionalism type education, where it's really difficult because it's hard to, like, that there's no standardized curriculum that everyone uses, and it's very, very difficult to know what resources to use to teach them, and also to provide a structure that is going to tackle every subtopic within this important bigger topic. So
Yeah, absolutely. And I think, the point that you were making before, like definitely we have had residents who really, really struggle with this, and they clearly get very frustrated, they get very angry, and they have challenges with their bedside manner. But that's not most of our residents, right? And even for the ones that aren't visibly struggling with it, I think most of them are sometimes having a hard time with this. I mean, I remember you from your residency, and always had an excellent bedside manner, but I'm sure there were times when it was just exhausting for you, right? It feels lonely when you're having these hard conversations, and no one has sort of normalized that these conversations are hard, and that you're going to feel angry sometimes, or you're going to feel sad sometimes, or you're going to feel inadequate sometimes during these conversations.
I wonder if there's a way, I know this is maybe like 10 years down the road or something, but like I know for myself, I have certain types of conversations that tend to be triggers, like very specific triggers for me. And maybe we can say there are 30 different types of conversations in emergency that we may have in the emergency department, just to throw out a random number there. And maybe there's a way to do some kind of testing where we find out the triggers, or we have residents self-report what they believe are their triggers in the department, like just pinpointing times they became just like immensely frustrated.
Yeah.
And then have specific lessons catered to their own needs. Because doing the amount of guidance and mentorship that we could put into a curriculum for just any, like, as a general blanket for every resident, it's an immense amount of material. And if they don't need very much help with one type of trigger that is bothering everyone else but not them, then maybe we can focus our efforts on the things that are really, really difficult for them. One of mine is some personality disorders tend to be triggers for me, and specific types of personality disorders. Yeah.
I mean, I think just the fact that you've sort of stopped and thought about it, and identified those things that you know are going to be difficult for you, I think that's probably where the fruitful training is, right? Like that idea of that sort of name idea, and identifying when you're going to feel a strong emotion, and sort of knowing who you are as a physician. I think it is a thing that we sort of leave our trainees on their own to figure out. I don't think that everyone stops and thinks about it to the extent that you have. And I think some of our trainees sort of benefit from being taught how to do that. And you're right, we're not going to be able to, everybody has their own idiosyncratic triggers, right? They're idiosyncratic kinds of patients or types of situations that are harder for them. But I think just teaching that technique of being in touch with yourself and your own emotions, and recognizing them, and sort of accepting that that's going to happen, I think that's really helpful for people.
Are there any tools out there to help us identify, either in ourselves as teachers or in our learners? You could, before you did an orientation, you could have them take maybe a little tool that would help them sort of sit back like we're doing right now. We're thinking about it. What are the things I really remember from medical school where you went, you know what, I still remember that encounter today, and I still look back feeling really bad about it. But at the time, it just seemed like, oh, I was told to go talk to this family, and I did, and I felt horrible about it. And I still remember that.
Yeah.
Are there any tools that we can utilize for ourselves or in our learners to help them identify and sort of just sit back, in the comfort of their own home or with their significant other, and sort of explore those things so they're ready to come to orientation exposure that we might give them?
So, and it's interesting because there's not a ton of research on this. Like, there's a bunch of research on sort of communication frameworks for speaking to patients, and there's a bunch of research on, burnout in physicians. But that idea of, like, sort of, as a physician, analyzing your own emotions, and thinking about your own emotional reactions to patients, I mean, maybe I'm missing things, but I did spend a fair amount of time sort of researching this and thinking about it. There's not a lot that's there. I would say the closest thing maybe is narrative medicine. But narrative medicine it's not specifically that, right? And I think narrative medicine may be a little open-ended for something like this. Like that paper that had the name technique, and the CAL was actually, they had a different mnemonic. It was calmer, and I didn't like the last 3 letters. That was one of the few that I could find that had a specific technique targeted at the physician and the physician's own emotions. Most of the research that's out there is sort of focused on the patient, which is understandable and appropriate, right? We're there to take care of them. But I think the problem with that is that it's very hard to take care of somebody else, to be emotionally available to somebody else when you're in an emotionally charged situation yourself. And there's not a lot of acknowledgement of that. And actually, one of the inspirations for this is, you know, our own hospital is sort of focusing on patient experience and appropriately trying to have our physicians communicate better with patients. But the sort of, and teaching techniques to physicians and residents to do that. And it's, you know, important and great. And, but it also, I mean, it can feel like just one more demand, right? On and especially with residents, they already have a huge cognitive load, right? Because they're trying to learn clinical medicine and they're trying to just navigate their way around the hospital. And we're not just asking them to do this, right? We're asking them to do a sepsis protocol, and we're asking them to do things with documentation. And like there's a lot of asks, and it can feel like no one's really interested in you, right? When they're asking you to do all these really difficult things, no one's acknowledging how hard it is. And so that's sort of where this came out of. And that one paper, it was very hard for me to find papers that addressed teaching physicians how to do that.
I really do love that toolkit.
I mean, is it AI generated?
Not a single tool that I would know how to use.
What's so funny is I think I can identify what all those things are and could probably use them, but I still, even though I've been doing this for more than a couple decades, there are times where I know something's going to get under my skin, and I know my learners are watching how I'm doing it, and I still feel inadequate.
Yeah. Well, thank you all so much. Any parting questions or comments for the session today? Right. Thank you, Dr. Kulkarni and Dr. Cotarello. This was excellent, an excellent discussion as always. So we will see you all next month when we'll have Molly Estes giving a session about the core didactics. So thank you so much. And we'll close for the day.
Thank you, guys. My email's in
Thank
the
you,
chat.
everyone.
Thank you, guys. If anyone wanted to, the videos or the slides, or, you know, wanted to collaborate with us, please don't hesitate to reach out. Thank you, guys.